The first talk is by a speaker who needs no introduction. Dr. Saravanan is a senior consultant at Aravind Eye Hospital, Coimbatore, and he will be talking on the role of invasive angiography in current day practice. Over to Dr. Saravanan. Thank you.
Thanks, Sharath, for this opportunity. So right now, this question arises mainly because we have comfortable non-invasive procedures to evaluate disease progression as well as response to treatment, mainly the OCT and the OCT angiography. So otherwise, this question will not be asked whether we still need a invasive angiography. So just go about since first when Novotny and Alves, they first did the human angiogram on themselves. Actually, Novotny performed the procedure on Alves, and this is the first angiogram capture in a human eye. So since then, we've been, the technique was popularized by Maumni from Baltimore, as well as Dr. Donald Gass. They had popularized it extensively and studying it, the fluorescent angiogram patterns in various diseases. Recently, what happened is that when they did introduction of both optical coherence tomography and the OCT angiography, so because it is non-invasive and very easily capturable images, now the question arises whether we still need this in today's time when we are mostly avoiding all this. The reason why we don't prefer the angiography is that all the side effects of the fluorescent dye, right from mild itching to severe cardiac arrest and anaphylaxis. So that's the reason why this question is being asked. Otherwise, and also the colored urine of post-operative, everybody is afraid of all this. And this cannot be performed in a few patients, like absolute contraindication being the known allergy, and relative contraindication being renal failure, cardiac patients, pregnancy, and people with asthma. So one thing which is absolutely missing in the optical coherence tomography angiography patterns is the leakage. That will only show the blood vessel and it will not show the leakage. It's a very integral component of various diseases, like you see in a CNVM or a diabetic macular edema. So we need to know that the dye is leaking from these places. Whereas the routine OCT will not pick up all these leakage patterns. So it gives a significant edge of fluorescent angiography in over the new OCT angiography. Just showing the difference of how NVD will look like in a OCT angiography which you see on the left and the fluorescent angiogram which you see on the right. So only it will just be showing the vessel, whether it is a new vessel or it's a IRMA. Sometimes you have a confusion because in the disc you can easily identify it's a NVD, but if it's in the periphery, you'll always be confused whether it's an NVE or a IRMA. Whereas in a fluorescein, you will see that immediately you can easily identify that the leakage is very visible. So one more disadvantage is that the current OCT machines only capture a small field of view and they have to take multiple scans to sort of integrate it into a mosaic pattern to give a larger field. Still, this is inadequate compared to the newer fundus fluorescent angiograph. Like this is a picture from the Optos. With one image, you can capture from almost 200 degrees from close to aura, you can capture, and the whole disease process is easily available in one single click. Whereas there you have to take multiple pictures to gain this sort of large. Even then, you can never parallel this Optos and the newer generation wide field cameras. And plus, in poor patients who are not very cooperative, it's very difficult to capture the OCTA. Significant media opacity is again very difficult to capture OCTA, whereas fluorescent angiogram can be decently captured. And one more thing is that some of the classification new diseases like the polypoidal choroidal vasculopathy, the OCT does not pick up some of the lesions very clearly. So here you can see that the presence of the small white dots, that's the polyps, and the underneath branching vascular pattern, which is easily visible here. But a lot of times OCTA will miss out on the polyps. It will only pick up the BVN, or the branching vascular network, and it will not pick out. Currently, you can see that this is a comparison of a OCT of a polypoidal choroidal vasculopathy. You can see that the BVN is picked up, but the polyp is missed out on. Polyp is only picked up on the indocyanine green angiography. Plus, there are a lot of companies which have their own algorithms and their own depiction of reports, and that sometimes becomes confusing and it becomes difficult to translate between different machines. The pictures between captured in different machines is usually not very easily captured. And if the segmentation is not proper, the automatic segmentation is not proper, you can get multiple mistakes actually happening. Here you can see that this is the original image captured by the segmentation done by the machine. The CNM is totally absent. But then we have, because we knew that the CNM is there, we have to actually manually resegment it to give the picture to depict the CNM. So if you are going by only the report, you can always easily miss optical coherence tomography picture. And also you have multiple artifacts, fluid showing an artifact here. And the So again, when you have like an OCTA will not show leakage, and when you have a new network and a mature quiescent network or a new active network, then it becomes confusing, because both will get picked up on OCTA, and you'll get confused whether to treat this patient or not. Whereas the leakage will give you the idea of activity for doing a fundus fluorescence angiography. And any media opacity, you tend to get a lot of artifacts. The presence of motion artifacts, the patient is moving the eye. Again, blink artifacts. So all these things can cause multiple issues, and the aneurysms, because of low flow pattern, they do not get picked up on OCTA. So you have to fall back on the fundus fluorescence angiogram. They're showing the example of the projection artifact. You can see that on the choroidal cut, you can still see the retinal network, that it becomes confusing whether it's a CNVM or a normal retinal blood vessel. So it's confusing. So all these projection artifacts can create a lot of confusion for a beginner. And when there is a significant retinal edema, like a branch retinal artery occlusion here, again, nothing is seen. It's totally obscuring this thing. And again, I'm showing example of some cases where you will absolutely need a fluorescent angiogram or andesite green angiogram. So polypoidal choroidal vasculitis, I told you, because the branching vascular network and the polyps are easily picked up on ICG, and it's gold standard. And for diagnosing RAP lesion, type 3 CNVM, you can see the right angle. You can see the right angle blood vessel dipping into the choroid and filling up the underneath network. Again, FFA and ICG are the gold standard to pick up RAP lesion, and it is easily missed out on a routine OCTA angiography. And again, central serous retinopathy, we want planning treatment, you need to know the leakage, which is totally absent in OCTA. So we have to fall back on FFA to all these patterns. You have the inkblot, smokestack, and the diffuse RP epilepsy in chronic CSR. All these will be missed out on a routine unless you are doing a routine FFA ICG. And all these inflammatory disorders like serpiginous choroiditis, VKH disease, as well as tumors like hemangioma, melanoma. So in all these cases, you have to fall back, and the routine invasive angiography of ICG and FFA plays an integral role. Currently, OCT is like a Nazari on the left, until it becomes as beautiful as the picture on the right. Still be the big role for invasive FFA as well as ICG. I'll stop here. Thanks for your attention.
Thank you, sir. An excellent talk as usual. So the debate still lies in favor of invasive angiography as of now. OCT has a long way to catch